Welcome, everyone. I want to welcome you all on behalf of the Newport Beach Public Library Foundation to our Medicine in Our Backyard series. This is the second lecture in a series of 8, and this is our 3rd year of this series, and we are so happy that it will be continuing on because the wonderful UCI has a plethora of doctors that they are willing to share with us. So we thank UCI for their partnership and for sharing their wealth of knowledge with us. I would also like to thank Mike and Polly Smith, who are members of the Newport Beach Public Library Foundation, and without whose vision and leadership this series would not be possible. Thank you, Mike and Polly. And just a few words about the Newport Beach Public Library Foundation before I hand it over to Polly Smith to introduce our speaker tonight. The Newport Beach Public Library Foundation exists because of you as members and as program attendees. Without your support, the Public Library, Newport Beach Public Library Foundation would not be able to provide programs such as these and to provide the financial and material support to the Newport Beach Public Library. So we are a membership organization, and we have membership in the back table, and we encourage all of you to become members of the Newport Beach Public Library Foundation. In addition to membership, it's important for you all to know about our programs. We run programs from October to about May each year, and there are many things going on. As members of the Library Foundation, you get advance notice and ticket discounts for all our events. So please make sure you check out our event information on the back table. And just a quick note about our first Witty Distinguished Lecture Series event. That's coming up this Saturday, October 29th. It's Lindsay Addario, and she is the world-renowned war photographer, and we still do have a very few tickets available. So you can either talk to me tonight or look us up on the Newport Beach Public Library Foundation website and purchase tickets. So with that, I would like to introduce Polly Smith, who will be introducing our speaker tonight. Thank you.
Thank you, Susan, and welcome to you all. Tonight, I'm very honored to be able to introduce our guest speaker. Dr. Ed Nelson is a multidisciplinary physician, scientist, and tumor immunologist. He conducts both laboratory and clinical studies, and his focus is on improving the ability of our own immune systems to fight cancer. Dr. Nelson received his medical degree from Oregon Health Sciences University, and then off to Stanford, and then off to Rochester, and back to Stanford again. So he has a wealth of education and training, and he has received numerous awards and patents. He is regularly named as one of America's top doctors and as a physician of excellence by the Orange County Medical Association. He is the chief of UCI's Hematological Oncology program. In addition to his teaching responsibilities and his work at the Chow Cancer Center, he recently opened UCI Health's Newport Cancer Center, which is in that big blue building that you see at the corner of 16th Street and Newport Boulevard. Now, please welcome Dr. Ed Nelson.
Well, thank you, Polly, and the Newport Library Foundation for the kind invitation. Can the people in the back hear me? Yes, okay. I tend to speak with my hands, and I tend to move away from the microphone, so if you cannot hear me, please give a wave or something, and I'll try and redirect. So the topic today is on new cancer therapies, but before one embarks upon new cancer therapies, it's a little bit important to understand sort of where we're at and sort of the terrain that we have to operate on. So tonight's presentation is really going to be divided up into several parts. So what I'd like to do is to provide you with some perspective on why this is such an exciting and at the same time daunting time for oncology. There's a lot of clinical and basic science advances which have occurred, and they're really the things which are allowing us to consider this concept of personalized medicine or individualized or tailored medicine, and of course the most recently announced moonshot. There are some examples that I'm going to share with you of entirely new therapeutic strategies, both their development and their clinical application, because they're very different from what all of us remember as chemotherapy that our family members or parents or grandparents experienced. And then I'd like to, as we're going through this, highlight some of the contributions that faculty of UCI, of the School of Medicine, have made and are making to this story, thus the medicine in your own backyard. So, what are we up against? Well, historically, cancers, tumors, were considered to be something that was really foreign. If you think about it, it's growing inside a body. It looks different, right? It clearly must be foreign. However, that actually turns out not to be the case. For decades, this concept of a foreign cancer, right, drove the search for a magic bullet. Right? That is, this something about the cancer that was unique, something that could be targeted to provide a cure. Right? And this spawned a lot of things. Amongst them were President Nixon's war on cancer, charged with defeating cancer in 10 years. We didn't achieve that. Searching for antibodies that would recognize cancer cells, there is a plethora of scientists whose careers lie on the discarded heap of activities trying to find antibodies directed at cancer cells to identify them specifically from other normal cells. Somewhere around the early 1990s, with the characterization of the leaf-from-meaning syndrome, the sequential molecular alterations that occurred from a polyp to a colon cancer, and then the definition of tumor-associated antigens. These are the things that the immune system sees. It became clear that the tumors were better conceptualized not as foreign, but as altered self. So minimally changed, but phenotypically and biologically quite different. So, what does it take to become a tumor cell? Well, the cell must first be convinced that it's receiving a signal to grow. Now, that can occur because you have overexpression or activation of the receptors. Classic example, breast cancer with HER2/neu. Right? There can be activation of downstream signaling pathways, and there can be circumventing sort of tonic negative feedbacks or inhibitory pathways. There will be no quiz, I promise. This is the signaling pathway for one receptor, epidermal growth factor receptor. Right? There are 4 family members, right? They heterodimerize in these sort of areas, and this is the electrical diagram. So for electrical engineers in the building, you'll appreciate the extent of this. You also have to convince the cell and make it so that it does not have DNA repair capabilities. So it actually turns out there are 5 different ways that the DNA and the genes in our cells can be repaired. Homologous recombination mismatch repair, nucleotide excision repair, DNA string-cross-link repair, and non-homologous end joining. You don't have to disrupt all of them, just one. This is the pathway for nucleotide excision repair. You can see all these proteins. This is single-strand break repair, and you can see all of these proteins. As you can gather, it doesn't take too much to defeat or abrogate or circumvent one of these pathways because they're involving multiple proteins. So cells also need to be told that they can't commit suicide. We call that apoptosis. So the cell kills itself off. And there are 2 pathways, the intrinsic pathway and the extrinsic pathway. The extrinsic comes from so-called death receptors. The intrinsic pathway comes from the cell perceiving that it's being stressed in some way that's untenable for its subsequent survival. So, this is the apoptotic pathways. Right, again, there will be no quiz. Right. So, there are at least 20 growth factors, and if we assume that one of those proteins along that big matrix also gets disrupted, then we have the receptors and we have one of the signaling molecules that gets disrupted. So there's 40 ways that we can convert a cell to not wanting to be growing all the time. 5 DNA repair pathways, we'll make a conservative estimate that there's 6 proteins that are really critical, that if they're fouled up, right, that would abrogate the DNA repair pathway. 2 apoptotic pathways, they involve a plethora of proteins, so we'll choose 10. So for the engineers and mathematicians, right, this is the formula. For the rest of us, right, if you disrupt 3 pathways and you have 90 potential elements, that means that you have 117,480 different combinations that can lead to a cell becoming a cancer cell. Yes, true. So the comment was, no wonder we all have it. Okay? So this is one of my favorite images, not so much because it's colorful, although it is, but back in 2000, when we first developed the gene chip, a group looked at 200 breast cancers. They all looked exactly the same under the microscope. And they ran the gene chip. And if you look over here, here's the full gene chip array. It's about 35,000 different genes. And you can see that they can cluster them in various ways, and there are ways to do that. But what's really impressive is that out of these 200, if you compare each column, which is one tumor, no 2 of them are alike. This was repeated in 2007 and 2008 by other groups. So if that's not difficult enough, subsequently we looked within a tumor, and we did biopsies in different parts of the tumor, some in metastases in different places, and lo and behold, when you look again, they're different even within the tumor mass itself. So different cells in different places look different on a molecular level. So, what's the take-home message? The take-home message is that cancer is far more complex than anyone imagined, even in the late 20th century. Even cancers that look exactly the same under the microscope can be very different at the molecular and genetic level. Despite this imposing challenge, we've actually made some remarkable successes, some of which I'll tell you about tonight. And anyone who says they can cure cancer in X, our lifetime, a decade, whatever, is either not well versed in either oncologic history or cancer biology. So a timeline. I know all of us in the room are 39, and so we can't remember back. Right? But prior to 1940, essentially the only thing that we had was surgical removal of tumors. Around the 1948-46, the first chemotherapeutic drugs came on the, if you will, on the market or in use. These were the nitrogen mustards and then drugs such as methotrexate. In 1956, we have a couple more drugs, 5-FU, right, chlorambucil in the early 50s, cyclophosphamide, and melphalan. All those drugs are still in use today. Additionally, in 1956 was the first demonstration of effective use of radiation therapy. Again, for those of us that are older than 39, you may remember the cobalt treatments that grandparents and parents may have had. This subsequently went on to be linear accelerators and more sophisticated development of radiation therapy, but it's important to remember that it really started just about 60 years ago. It was in 1965 and 66 that we first developed the concept of combination chemotherapy, not just one drug, but adding them together. And this was the first time that we were able to cure cancer, right? And that occurred in the setting of Hodgkin's disease. Subsequently, we will go through the 70s and 80s, and really there's only one new drug, cisplatin, that came on the market. Then we hit the late 1980s, and things start to pick up, right? The ones in blue are drugs which we don't use to treat cancer, but they're drugs which help us to give treatment for cancer. So these up here are drugs which help with nausea and vomiting. These drugs down here are growth factors that help our bone marrow work better after we give chemotherapy. And then over the next roughly 18 years, you can see that we start to have more medications come on the scene. We have Rituxan and Herceptin, two antibodies that recognize molecules on the outside of very specific cells. We have Gleevec, right, which was the first molecularly targeted therapy. It was directed against the chromosomal aberration in chronic myelogenous leukemia. For those of you that were here last year, or perhaps the year before, Dr. Richard Van Etten, our Cancer Center director, presented work. He was instrumental in defining this particular molecular arrangement that spawned this drug. And then subsequently, the ones in red are other molecularly targeted therapies. So prior to 2008, we had 13 FDA-approved molecularly targeted therapies. So let's look at the next, if you will, 8 years. This is what it looks like. So now if you look again at the red, right, these are all new molecularly targeted therapies. Right? Culminating in 2016, already with 5 new agents being FDA approved. So in an 8+ year period, we moved from 13 to being 54 new FDA-approved agents, right? So from 13 to 67, right? New agents. So tonight, I want to share with you just some of those stories. Specifically, I want to focus on kinase inhibitors in solid tumors. We're going to focus on lung cancer and a molecular derangement called ALK-EML4. We'll also talk a little bit about ROS because that's part of the story. We'll talk about kinase inhibitors for lymphoma and leukemia, specifically 2, BTK. We'll talk about what that is, and Pi3 kinase. And then we'll talk about immune checkpoint inhibitors, specifically focusing on the PD-1 axis. And then at the end, I want to share with you some of the work that we're doing at UCI, trying to expand this repertoire a little bit. Here we go. So, 2011, we get this drug, crizotinib. 2014, we get a second generation, and at 2015, we get another second generation inhibitor. These drugs were directed against the ALK-EML4. Then we'll talk about these two drugs, ibrutinib and indelilisib. Right? They're in lymphomas. And then in 2011, late 2013, and late 2014, we're going to talk about the PD-1 checkpoint inhibitors. All right, ALK-EML4, ROS, MET, and others. So back in 1994, a particular type of lymphoma called an anaplastic large cell lymphoma had a gene identified with it that was responsible for its malignant behavior, and it was nicknamed or labeled ALK. It turns out that it's disrupted or active in about 60% of anaplastic large B cells. It has a normal function in the nervous system. In 2007, Pfizer published the development of a dual ALK, or anaplastic lymphoma kinase, and MET inhibitor. This would subsequently become crizotinib. In 2007, the EML4 ALK oncogene fusion protein was identified in non-small cell lung cancer. Sorry for the abbreviations. Non-smokers, it was mutually exclusive with mutations in the epidermal growth factor receptor. Remember that big electrical diagram mess? Yeah, that's where that one's at. Or KRAS mutations. In 2011, the first clinical trial of molecularly targeted kinase inhibitor therapy for lung cancer was published. Subsequent to that, we've defined lung cancer in a very different way. So, we know that about a quarter have mutations in KRAS, about a little over a third in EGFR, maybe about 7% BRAF, ALK turns out to be about 5%, so forth and so on, and with roughly a third being other. We don't know what their molecular derangement is. This is Dr. Ignatius Wu. He's a member of our faculty. He's within the Hem/Onc division. The reason that I show his picture up here is because Dr. Wu leads our lung cancer program. UCI, was the only site west of the Mississippi that participated in the original crizotinib trial. And it is all due to his persistence. So, this is the original report. This is progression-free survival. This is the curve for the trial. The pink is the 95% confidence interval. And if we're looking at this, we go, gee, 24 months, only about, you're down to a third, right? That's not very good, right? Well, it's actually not too bad because chemotherapy comes like down here, right? And more importantly, this is we call this a waterfall plot. What's so interesting about this is that this is the amount of change in the tumor mass. If you get down to minus 100%, it means the tumor's all gone. If you look over here, right, with this pill, a crizotinib pill, not chemotherapy per se, right, you were able to get some people to have complete responses. This is what the progression-free survival looks like relative to chemotherapy. The overall survival sort of looks like they come to overlap. Part of the reason for that is that people were allowed to flip-flop between the two arms. But this is pretty significant, and if you're on this curve, you're a whole lot happier than you are on this one. So, this was Dr. Wu's initial work, right? And then he noticed, or he knew from his being involved with the field, that there were other mutations, those other mutations in lung cancer. And crizotinib, he also knew, because it was developed, remember, as a dual inhibitor, right, against both ALK and MET, that there might be a way that it could be used for those lung cancers that have MET mutations. So we tried, and it works. Furthermore, within lung cancer, there's a population that have ROS1 overexpressed. Now, this isn't mutated. It just means that there's more of it. And when that happens, right, it also defines a very specific subset of lung cancers. And it turns out crizotinib can also inhibit ROS1. Right? And so crizotinib now works in ALK EML4, it works in MET, and it works in ROS1 amplified lung cancers. So now we're not just at 5%, right? Now we're adding another 3% and another 2%. So now we're up to where this drug can actually give you some benefit in 10% or thereabouts of lung cancer patients. Additionally, Dr. Wu, working with some of our GI doctors, was able to identify ROS1 rearrangements in various GI cancers. And there's an ongoing clinical trial now at UCI to treat those with crizotinib. Subsequently, utilizing that most recent second generation ALK EML4 inhibitor, alectinib, Dr. Wu was able to demonstrate that taking a pill can treat brain metastases of lung cancer. So for those of you that, again, are unfortunate enough to have had experience with lung cancer that has, or had friends or relatives with lung cancer who have had it go to their brain, it is essentially a death sentence. Right? There's not a whole lot that we can do about that. Sometimes we can take it out surgically, but it comes back. We can irradiate it, not very effective, or only effective in the short term. But utilizing, again, a pill, right? He was able to have a brain metastasis shrink away to nothing. Right? Truly impressive. All right, that's great. You got this great drug, but what happens when I take it? Wow, crizotinib. So you do have some diarrhea, you have a little mild nausea, but you have to watch your liver. And surprising, for reasons that we don't understand, a lot of folks have visual changes. You have to watch your EKG, right? And you can get inflammation of your lung. Our second generation, if you notice, right, there's fewer side effects. Right? Fewer side effects, and this is the one that gets into the brain. So although we've developed these molecularly targeted therapies, what's happening now is that as the second and third generations are coming along, we're getting an improved, if you will, side effect to therapeutic ratio, right? So they're less toxic, and yet they're doing the job, and in some cases doing it better. All right, what else is Dr. Wu doing? Well, he's got another phase 1 trial on a MET EGFR inhibitor, another inhibitor for a second generation MET inhibitor. This is in this setting that is resistant to our crizotinib and other inhibitors, so he's working on another one. And we have another one which is looking at another molecular derangement in lung cancer called RET. Right. So I'm going to shift gears now to the next two. So to tell you a little bit about that, you have to learn a little bit of immunology. Sorry. Right. So in your immune system, you have these things called lymphocytes. They're part of your white blood cells. We divide them into two flavors. One is called B, one is called T lymphocytes. The T lymphocytes do a lot of things. They're basically helpers and killers. They help you to do lots of different things, make antibodies, get rid of viruses, etc. But the B lymphocytes, these guys are only responsible for making antibodies. That's what they do. Right? So B lymphocytes, it turns out, are the predominant form or the predominant cells that become malignant in lymphomas. This is Dr. Susan O'Brien. Dr. O'Brien joined us about 2 years ago. When Dr. Van Etten came to be our new Cancer Center director, his first hire was this individual. Right? Dr. O'Brien comes to us from MD Anderson. She was instrumental in the development of both of the drugs that I'm going to be telling you about. So, this is our little cartoon of the immunoglobulin molecule that sits on the outside of a B cell. When whatever the immunoglobulin molecule can see engages it, we get a signal through the B cell telling it that we need that antibody. You have to grow. You have to make more B cells to make those antibodies because we need them. If you notice, here's this little guy called BTK. Right? It's critical for this signaling through one direction. This Pi3 kinase is involved with another signaling pathway in the same way. Both of these tell the B lymphocyte that it's time to grow. So, chronic lymphocytic leukemia, or CLL, and lymphoma both have these molecules, and they're both important for their growth. So in 1983 was when Pi3 kinase was first identified. It was first identified as being associated with an oncogenic viral infection. But it turns out that it's really involved in a large number of signaling pathways, and if it's in a large number, you can imagine that it's also involved in a large array of biological behaviors, including cell growth, proliferation, motility, differentiation, and survival. Pretty much everything that a cell does. In 1994, a particular tyrosine kinase, this is just another signaling molecule, named Bruton's tyrosine kinase, or BTK, was identified. It was actually responsible for an immune deficiency, an inherited immune deficiency. But it was found to be absolutely critical for B cell development and survival. In 2005, this PCI 32765, a BTK inhibitor, it would later go on to become ibrutinib, was synthesized and started clinical studies in 2009. Similarly, in 2006, this CAL-101, a Pi3 kinase inhibitor, later would become indelisib, was developed and also entered clinical studies in 2009. These are patients with CLL who have become refractory to our normal treatments. And they were treated either with ibrutinib or with whatever the physician could come up with. And as you can see, right, there's a very dramatic difference between the survival if people got ibrutinib, the gray line, versus if they got whatever else the clinician had at their disposal. Later, we started comparing it to things that we knew should work or do work: fludarabine, chlorambucil, bortezomib, pinabastat, rituximab, everolimus. All of them do not do as well as ibrutinib, sitting up here. There are risk factors for CLL. It turns out that if you are missing part of your chromosome 17, that's a bad thing. You're at higher risk. You're likely to have behavior of your CLL that's more aggressive. And here we see that with ibrutinib, there's really no difference whether you have the loss of that part of 17, chromosome 17, or not, in contrast to using an antibody sort of like Rituxan, where it is different. So it looks like this, again, this pill, right, can actually make high-risk CLL not be so high risk. This is just a different and a longer-term study, again showing essentially the same thing. So there's some unique things about these two drugs. One of the things is that you get a really rapid decrease in the lymph nodes. So people that have lymphoma have lymph nodes that are big. That's how we know that they have lymphoma. Right? It goes down very quick, but this is what the lymphocyte count in the blood does. So for reasons, again, that we don't exactly understand, in the same time that the lymph nodes are going down, down, down very steeply, the lymphocyte count in the blood is going up, up, up very steeply. And then over several months, right, it actually comes down, back down to the normal range. So why am I telling you this? Because nothing like this has ever been seen with chemotherapy. And that begs the question, if we've been trained and we've been using chemotherapy a long time and we know how it behaves, but then we start using drugs like this, all of a sudden we get to see different side effects. similar to what I showed you with the crizotinib. So this is the other drug, the Pi3 kinase inhibitor. Again, using it with an antibody, Rituxan. And here we see progression-free survival. It does better. Overall survival, it does better. And when we look in the same way for this loss of the chromosome 17, again, it makes it so that the two curves overlap. So both drugs convert high risk into not so high risk. So what things has Dr. O'Brien been up to, right? Well, she did the initial therapy, the initial phase 1b and 2 trial. That's her, right? She looked at this, this medication, right? Because it's a pill and it blocks signaling. So you might imagine that if you are blocking the signal, but then you take away the block, what happens, right? Maybe the tumor grows back. And so there's ongoing discussion and ongoing investigations as to what happens if you stop and can you restart. How do we use this brand new drug? So additionally, there are studies looking at combining that drug with standard chemotherapy and antibodies. So maybe fludarabine and Rituxan and ibrutinib would be better than ibrutinib plus Rituxan. Additionally, right, you might think about comparing indelisib with Rituxan, right, and see if that works, much like the ibrutinib and Rituxan. And if you're really gallant, you might actually think about combining both of them. So, ibrutinib side effects. Again, a little bit of diarrhea, muscle aches, rash, some low blood counts, which can lead you to some infections. Surprisingly, there's a risk of bleeding. It turns out that it affects platelets. Some fatigue, a fever, and again, we have to be a little bit concerned about the heart. Indelisib, again, GI side effects, liver toxicity, pneumonitis, low blood counts, fatigue, fever, mild nausea. No hair loss, right? No uncontrolled nausea and vomiting. Right? The things that would make you, if you will, walk down the street and people go aghast because, oh my goodness, you must be getting chemotherapy, they're not going to happen. Right? Not that they're the easiest things to take, but these are pills and you can take them and generally tolerate them well. However, there's another component to this. Ibrutinib. I told you we don't know how to use it. For sure, we don't know how long you have to take it. We don't know if you can stop and then restart. Those are all things that we're addressing. One of the reasons that we're addressing that is that there is this thing called financial toxicity. The cost of ibrutinib, right, for most people who have co-pays for their insurance, it will run them between $3,000 and $5,000 a month. Right? It's an extraordinarily expensive drug, yet it works phenomenally well. And so we, the field, have to figure out how to use it the most effective way. Or, much like the crizotinib study, hope that there are second and third generations that are coming down the pike that are maybe less toxic, work just as well. And in fact, the second generation ibrutinib agents are in clinical trials, and the clinical trial is being done with 1 year of treatment. End of story. Right? So even if it works as well as ibrutinib, they just took the financial toxicity off the table, right? So I told you that if you were really gallant, right, like Dr. O'Brien, you might actually think about combining these two. Right? So this clinical trial that we have up and running at UCI is testing a second-generation BTK inhibitor and a second-generation Pi3 kinase inhibitor as dual therapy for relapsed and refractory lymphomas. We also are comparing that one of the second generation BTK inhibitors versus ibrutinib head-to-head. Right? Let's find out which one's better. So I'm going to shift again now to the checkpoint inhibitors. So for the immune system, if you get a virus, right, the virus expands, your immune system takes off, gets rid of the virus, and then somehow you have to have that immune system shrink back down. We've all had a sore throat. We've all had the swollen glands underneath our jaw, right? And then when we get feeling better, they go down. Well, what would happen if they didn't, right? Every time you would get an infection, it would go up and up and up and up and up, right? We'd end up being one big lymph node. So there has to be a way for the immune system to shrink back down again. Turns out there are. There's actually multiple ways. So for a cell, a T cell, to be able to do its job, it has to see something, and it sees that through its receptor called a T cell receptor. And then it also needs to be given another signal that says it's okay to do what you need to do, and we call that signal 2. And that's these guys up here. Actually, this one and these two. When that happens, this molecule, CTLA4, this molecule, PD-1, now are expressed on the T cell. They're negative. They shut things down. So after the T cell is all jazzed up, these molecules come up on the surface and they put the brake on the immune system. Tumors, being rather smart, have figured out that if they express these sorts of molecules, they can actually shut down the lymphocytes. So, again, for the timeline. In 1990, a homolog of CD28, that's signal 2, was identified, and it's CTLA4. In 1993, PD-1 was identified. Right? In 1995, the opposing effects of CD28 and CTLA4 were recognized. That is, that's the first time in 1995 that we recognize that the immune system has molecules that can put the brakes on it. In 1999, the ligands for PD-1 were identified and were ultimately found to have a similar inhibitory signal to that of CTLA4. And then in 2011, anti-CTLA4, ipilimumab, was approved. 2 anti-PD-1 antibodies have been approved, one in 2014, nivolumab, and 2015, I can't even say it, right? And most recently, an anti-PD-L1 antibody. All right. Most of this work was done in melanoma. So in people that were treated with ipilimumab for advanced melanoma, right, if they got standard treatment, this was their curve, this gray one. And by year 5, this curve is down on the axis. It didn't matter whether you gave a vaccine or not, you had this plateau. Not a lot, maybe 20%, but 20% of the people that got ipilimumab had their disease stay away for a very long time. Potentially, we think, cured. So with the checkpoint inhibitor, if you're taking the brakes off the immune system, you might expect that there'd be some rather unusual side effects. And there are. If you start here, and this is your spleen, at week 12, your spleen is about 25% bigger. Right? And if we look on a PET scan, it's really, very, really active. Right? And then we go to week 21, and lo and behold, it's back down where it belongs. Same thing happens with the tumor. Right? Here's before treatment, 8 weeks. If you look, it's bigger. Right? Here to here, it's bigger. But once we're out at 4 months, it's down next to nothing. So, we were all taught many years ago, when we give chemotherapy, we look after the first 2 cycles, which is typically 6 to 8 weeks. Right? We start using this drug, we have to retrain our oncologists. You don't look until after 12 weeks because you won't know. You won't know whether the tumor is growing because the immune system is working or the tumor is growing because the tumor is growing. So don't look, right? Because you won't know what to do with the information. Entirely new concept, entirely new way of treating our cancer patients, and one that is hard for our cancer patients to understand, right? And so it takes some time talking to them about these new treatments to help them to understand why it is we're not doing things the way that we used to do it. All right, PD-1. I told you in 1993 it was isolated. It turns out it was actually isolated from pancreatic cells. PD-L1, these are the ligands for PD-1, and they were ultimately found to be responsible for peripheral tolerance. That is, that's the reason your body doesn't attack itself. So, there are lots and lots of PD-1 clinical trials going on at all of these different sites, different types of tumors, and even with some things like sepsis, bacterial infections, and hepatitis. There are also PD-L1 clinical trials, and they're all over the place here too. So, this is nivolumab, right? Opdivo, if you want the trade name. Right? This is overall survival. Again, these are advanced melanoma. Remember that at 5 years, right, the best we could do was down here, right? And Nivo does a little bit better than ipilimumab. If we overlay, right, the Nivo versus the ipilimumab, you can see that it does just a smidgen better. If we look here, right, here's ipilimumab, and here's our other pembrolizumab, right, Keytruda, right, which is up here. Again, about the same as the nivolumab. If it works in melanoma, maybe it works other places. And so here's an example of utilizing a checkpoint inhibitor in lung cancer. This is the same type of cancer that Dr. Wu treated, right? And here's the chemotherapy, and here is the immune checkpoint inhibitor. Right? These are just the responses. And better is farther this direction, so they do better. Here again is the other PD-1 antibody. It sits up here. Here's the chemotherapy. Looks essentially the same as the Nivo. Right. Here's a renal cell, same thing. Everolimus is the standard of practice. Nivo does better. Right. Here's lymphoma, refractory Hodgkin's disease, does better. Right. There's a rare tumor in the skin called a Merkel cell, really rare. Right. But if you can't cut it out, right, and it comes back, it goes like this, right? Here, just with the immune checkpoint inhibitor, we're looking at having folks not have their tumor grow, right? Even out at 6 to 12 months. So there's another new, if you will, second generation anti-PD-L1, right? And this is looking at bladder cancer. And this again is showing that our PD-1 actually does a little bit better than our standard treatment. Same thing with the lung cancer. Again, chemotherapy versus the checkpoint inhibitor. So we've talked about PD-1, we've talked about CTLA-4. Is that all there is? Well, the answer is no, right? So we talked about being able to activate the T cell through CD28. It turns out there's other molecules that will activate. We talked about CTLA4 and PD1, PDL1, so these guys. But it turns out there's a whole bunch of others that are inhibitory also. So there's a lot of work being done now as to what else could we be using to potentially get above that 20%, right? How can we get it up? So, balanced immune system, right? If we tip it over, make it work too hard, we end up in problems like autoimmunity and allergic reactions. So what happens, right? Well, you get autoimmunity. You get hepatitis, dermatitis, mucositis, thyroiditis, hypophysitis, adrenal insufficiency, iritis, right? Essentially any itis that you can imagine, you can get with this. Same thing with PD1, although there's some unique features. Pneumonitis is one of them. Okay. I told you that we sort of end up down here in this 20, 30% maybe, but what we really want to do is to get up here. Right? And so that's what we're trying to do now. So, what do we have at UCI? Well, we have clinical trials with various immune checkpoint inhibitors in bladder, cervical cancer, colorectal, esophagus, head and neck, kidney, liver, lung cancer, and ovarian. The names out here are the physicians who are leading those clinical trials. What I want to do now is shift to some of the work, some of the research that we're doing at UCI to try and expand that repertoire. So, one of the things that we've thought about is people often ask us, can stress cause cancer? Well, we don't think so. But stress, chronic psychological stress, actually does have an effect on your immune system. And so in cervical cancer patients who have been treated, we know that their quality of life is really poor after their treatment, and they suffer from this chronic psychological distress. So, we know that immune responses can be classified at least two different ways. One is Th2, which is the one that makes antibodies. Th1 is the one that you use to fight off viruses. You can think of them as being on opposite sides of a seesaw. Th2 over here, Th1. So if you've got a lot of Th2, you're not going to have much Th1. And we believe that the latter, the Th1, is most effective at destroying tumor cells. Chronic stress causes the immune system to move more towards making Th2. So this is work with my colleague, Dr. Laurie Wenzel. She's a behavioral scientist and our cancer survivorship person. She's very interested in gynecologic cancers and thus the interest in cervical cancer. So, if there's a psychological, physiologic stressors and it decreases quality of life, then you have increases in cortisol, you have increased Th2, but that's bad, right? It diminishes the anti-tumor response and you get a poor clinical outcome. So what if you could change it? Right? What if you could do something to help relieve the stressor so that now the stress response goes down, these go down, but now you increase the Th1, decrease the Th2, and maybe have an improved outcome. So Laurie and I ran a clinical study, an initial clinical study on 50 cervical cancer patients. And this way is Th1, this way is Th2, up here is improved quality of life, this is decreased quality of life. And as you can see, if you improve your quality of life, you get more Th1. If you have a decrease or you stay the same, you stay out on the Th2. It was the first demonstration, if you will, of a mind-body connection. Right? Subsequently, we did a large, little over 200 patient trial that was published a couple years ago, year and a half ago now, sorry. And what we see, these are the cytokines that are characterizing Th2. And as you have an improvement in your quality of life, you actually have decreases in each of those cytokines. Entirely consistent with what we saw in the initial pilot study. So, if you will, this is before, right? And this is after, right? So, back to this guy. Again, no quiz. If we're looking at these sorts of diagrams, these sorts of systems, right, it asks, or it begs the question, how do you choose something out of here to try and target? What do you do? Right? So this is a representation of all of those kinases that live in our cells. The ones that are circled, right, are the ones that we can target. Right? There's a lot of them out there that we can't target yet. So we have a clinical study that we've just started that we've named the Pathway Analysis for Individualized Network Therapeutics for Cancer, or PAINT Cancer. It's a pure feasibility trial. It's to see if we can look and give a better picture as to what's going on in a tumor. We base it on the fact that germline mutations, or these fusion proteins, are actually a very modest percentage of the things that go wrong in a cancer cell. And if you think about those diagrams, right, it would be impossible to have sufficient commercially available molecules to target each and every one of those nodes. Right? We couldn't do it. Right? And so this argues for a systems biology approach. That's a coin phrase, to examine the networks of biological and signaling pathways in order to identify targetable nodes. So we embarked upon a pilot program focusing on this tumor network analysis, and utilizing a new technology that I'll share with you, we can look at about 1,200 genes, their products, and we can get now a picture of what's happening within that cell. So this is our technology called Nano String. Very cool, right? You have a gene product, right? And you have two little probes, right, that are complementary to that, one of which has a whole bunch of colored molecules on it. Right? And the arrangement of those colors ends up being a barcode. Right? So you can capture this probe that's connected with a molecule and that gets this probe on it, and that represents a very specific gene, a very specific message. And you can then ask a machine to capture those barcodes, and it can count how many look like this, right, and give you an actual count of how many molecules you have for each one of those 1,200 genes. This is some data from our first 12 tumors that we've run using the nanostring. Each column is, again, one of our patients, one of their tumors. Red is more, blue is less. And again, just like the gene chip analysis, they're all different. But what's really interesting is that if you just look at this group right down here, and I've blown it up here, you start to see some things that we've talked about. RET, right? Where are we? ROS1, right? One of those tumors has ROS1, right? So if we knew that that was the case, that that pathway was elevated, why wouldn't we try crizotinib, right? Or one of the other agents, right? I don't need to know why, right? ROS1 is up, right? But I know I have a drug that will target it, right? ALK, up here, right? Amongst others. This is sort of how we have to start thinking about things, not so much as that electrical diagram, but rather as a spider web, right? And it's where we have to rely on our computational biologists and our mathematicians to help us understand this so-called big data. So, I hope that you came away with a perspective on why this is such an exciting time and yet such a daunting time in treatment of oncology. It's phenomenal the pace of change. We talked a little bit about some of the new things that are happening, both clinical and basic science, that like the Nano String, that is allowing us to get to this precision or tailored medicine. We talked about 3 different types of new therapeutic classes, right, and how they were developed. And we highlighted a few of the contributions of some of the faculty, i.e. the medicine in your own backyard. So with that, thank you. Take it. I'll take some questions if you would like, if you're not too hot or too tired. Yes, ma'am.
I am curious about how some of these drugs
So the question for those of you in the back was, how does the healthcare system that we have, how does that impact the sorts of things that we do? And it was pointed out that clinical research is done in Canada and the UK and other places where there is a single provider model, but they're also done in other places also. So the shortest answer to your question is it doesn't affect us. The reason it doesn't affect us is because about 14 years ago now, the state of California passed Senate Bill 37. Senate Bill 37 said that for any NCI-approved cancer clinical trial, the third-party payers had to pay for it, for the standard care, right? Because UCI and our group is part of an NCI-designated comprehensive cancer center, all of the clinical trials that go through our approval process are by definition NCI approved. So when you come to UCI for a clinical trial, right, what is standard of care will be billed to your insurance provider, whatever that ends up being, and the hospital system will take whatever that the provider would normally reimburse for that. The study parts, right? The added x-ray or the added lab test or the added office visit, those have to be covered by the sponsor or by the organization. Right? What happens as we evolve into other systems, I think, is really, it's like trying to look into a cloudy crystal ball. I don't know. I know that we have to pay attention to the healthcare dollar. We have to be good stewards of the healthcare dollar. We have to be good stewards of the research dollar. But we also have to invest now so that the molecules that were discovered in the 1990s that now give us these new drugs 25 years later, right? If we want our children to have new drugs and new approaches, we have to invest now. Right? It takes that long. So I think as a society, we're confronted with 2 sort of conflicting priorities, really, right? We can't have our healthcare budget continue to go through the roof. We have to care for our patients, but we also have to invest in the research. And that's a discussion and a debate that I think has to be taken very seriously, and really needs debate from all sides for us as a society to come to grips with what we really need to do. Yes, sir. Yeah, so I don't have exact numbers for you. If you look at all the mortality in the United States, a little over 1/3 is due to cancer. Right? A little less than that is heart, right? A little bit less yet is stroke, right? And then there's a whole bunch of miscellaneous that fills out the rest of it. In terms of the research dollars, there's no doubt that the NCI, the National Cancer Institute, gets more than its fair share of the NIH budget. Right? Has since President Nixon declared a war on cancer. I'll give you my view as to why that is. I tell my fellows that if they have any questions about how their patients feel about cancer, they should go out on the street corner and poll the first 100 people that go by and ask them how they want to die. None of them will say cancer, right? I want to die in my sleep. I want to die of a massive heart attack, right? Right? Not one of them will say cancer. So cancer comes with a very emotional overlay. And I think that again, sort of back to our society, it's a scary thing. And things that scare us, we tend to say, gosh, go for it, right? You gotta work on this. And I think cancer is no different. So did that answer your question? Questions? Yes, ma'am. Right. So the point was that our use of alcohol and tobacco imparts a very significant cost to our healthcare system, and that cost has never been fully compensated from the tobacco companies and others, and that might be one way to help our healthcare system get back into fiscal balance. Yes, sir. And then you. So the question was, for non-Hodgkin's lymphoma, is Rituxan the best medicine? It depends which lymphoma you have. Right? If you have what's called mantle cell lymphoma, right? A bad actor generally, right? In the last 18 to 20 months, ibrutinib, the BTK inhibitor, has displaced chemotherapy as the best drug for that particular type of lymphoma. So it changes, and it depends on which type of lymphoma you have, right? It depends who you ask. The question is, how many types of lymphoma are there? In 1980, we had a classification scheme that left us with essentially 9 to 10 different types. In the early 1990s, the pathologists went together and they developed what was called the Revised English American Lymphoma Classification System, or the REAL classification system. It grew to 170 different types. Since then, we've pared it down because 170 is just unmanageable for the average clinician. And so now we're down to about 70 or thereabouts. Ma'am.
Is UCI doing any work on pancreatic cancers?
Yes, they are. Yes, we are. Sorry.
Gaining any grounds?
Yes. So we're fortunate, I'm fortunate, to have a really outstanding individual leading our pancreatic group. It's Dr. Tara Siri. And Dr. Siri is doing some really outstanding work looking at things such as giving chemotherapy to shrink the tumor before the surgeons go in and try and take it out. She's also has a very good relationship with a group up in Seattle who are looking at very unique ways of getting drugs into the pancreatic cancer. Pancreatic cancer is really tough to get drugs into. It utilizes an enzyme to essentially digest away some of the stuff that makes it hard to get in there. So all of those things, she's got clinical trials going with that. She works with our surgical colleagues very much as a multidisciplinary team, and they're one of our best. So.
How many clinical trials are you running right now, and how would people be chosen for that?
So the question was, how many clinical trials are we running right now, and how are people chosen? So, the total number of cancer clinical trials when I last looked was 163. It's not so much that you're chosen as that we have a clinical trial for which you are eligible. So when I took over as division chief, one of the first things that I did was to ask our faculty to arrange themselves into teams and to focus just on one or two types of cancers. So I asked Tara, Dr. Siri, take over hepatobiliary, do liver and pancreas. That's what I want you to be the expert in. Dr. U, I want you to do lung. Right? That's what I want you to do. Dr. Diani, I want you to do colorectal. Dr. Nangia, I'd like you to do head and neck. So what we have now is we have individuals who spend their whole career, their whole energy on being an expert in that very specific narrow field, knowing what is happening, knowing what the cutting edge is, knowing where the new questions are and what we should do and how we should proceed as a field. So if you have a friend, family member, who has a particular type of cancer, we would ask that you contact us. You can either call the call center or you can ask your physician to contact us directly. And we're happy to see people and ask and look at them and their situation and say, do we have a clinical trial that would fit for you? And if we do, then we'll work with your doctor to coordinate that care. If we don't, two things happen. We ask if you would be willing to think about clinical trials elsewhere. We have a very good working relationship with City of Hope and UCLA and Cedars and USC too, actually, in some domains anyway. And so we'll help find the clinical trial. And importantly, part of the reason that we have our site in Newport is that it's onerous to come in and out of a big academic center. And so part of what we want to try and do is to, as much as possible, have care close to home, right? Even if it is on a clinical trial. So we sort of have to work with each patient, with each situation. Oh my goodness.
What level of understanding exists as to the best treatment for MDS?
The level of understanding for the best treatment for MDS. Poor, right? I don't think we know. Bone marrow transplant has certainly been one of the things which we've used, and that does work, it does help. Some of the histone deacetylase inhibitors work, but there's nothing that's a home run, right? So I don't think we have a good handle on it. I think we've got a lot to learn and a lot of work to do. I'm going to tout another new colleague. Dr. Angela Fleshman is working on understanding what happens when the stem cell is in the bone marrow, what makes it stay there, what makes it work, what makes it grow, and importantly, what makes it not grow, right? Why do things like MDS occur? And she's got some really interesting data that I'm really anxious to see how it unfolds over the next few years. So I'm going to go there, and then I'll come back.
Breast cancer, I haven't heard any reference to breast cancer this evening. How does molecular targeted therapy play out in that arena? Because that's a huge, huge need.
Right. So, my UCLA colleagues always give us a hard time because they argue that Herceptin was a molecularly targeted therapy. It was targeted against HER2/neu. We sort of have to give them that, I think, even though it's an antibody. But we do have different kinase inhibitors, right? So, for example, the EGFR pathway that I told you about there, that horrible electronic-looking thing, we have molecules that will inhibit various portions of that signaling pathway from the receptor on down. Probably the most exciting thing that's happening right now is some inhibitors that are working on the control switches for the cell cycle. They're called CDKs, right? And it looks like the early data looks really promising, particularly for the more difficult triple-negative breast cancer. So I think there is work moving along that line, but it's breast cancer has lagged behind a little bit in terms of things like we have done in lung cancer, and certainly in the lymphomas, in part because I think everybody's been really focused on the Herceptin and hormone receptor side of things. But I think there's a lot more to be ferreted out from there to make it a less toxic treatments. Yes, so we actually do have a clinical trial of the CDK4 inhibitor that's open. Yes. All right, I promised somebody else in purple. Where was it? Yes, ma'am. MDS. What is MDS? MDS is myelodysplastic syndrome. It's where your bone marrow basically doesn't work very well. And the word I use for our patients is that your bone marrow just gets really tired, right? There's not a lot of stem cells. Sometimes there's scarring in the bone marrow itself, the place where the stem cells ought to be. But like I said, we don't understand the biology as well as we should. All right, I'm going to go way back there. The gentleman. Yep, you.
I don't think I saw any graphs.
So the question is, in CLL, there are indications for starting treatment. And if we have these promising new agents, why not just start now, right? Well, they come with some cost, biologically and certainly financially. CLL is one of those diseases where you can live with CLL for a really, really long time, and it can not cause you any trouble. And you can see your doctor, every 3 to 6 months, and they say, yep, your blood count's right where it was, thank you very much, and go on about your life. But there's also the ones that are at high risk, and those I think we could move into the front line, and there's actually a clinical trial to do just that, right? To see if that moving it up front, ibrutinib as the very first thing we do, if that's better. But oncologists are always helping our patients to strike a balance between their quality of life and their duration of life. Our job is to maximize that product, right? It doesn't do any good to have someone live for 5 or 10 years if they're miserable for 5 or 10 years, right? That's the wrong thing. That's just torture. By the same token, if by a little bit of decrease in quality of life, I can get someone for a short period, I can get them to have 5 or 10 years, 2, 5, 10, something, then choosing not to do anything or not offering anything to the patient is also probably not the right thing to do. So decisions on patient's treatment is very much a dialogue between the patient and the physician, because every patient's perception of their quality of life and how important it is relative to how long they want to live, that's really personal. And so it takes time for the oncologist to talk with our patients and to be able to help our patient inform us and us to inform them so that we maximize that product for each and every patient, and it will be different. Yes, ma'am. So the question was, if you have cancer in one part of your body, does that mean that that's where it arose? The answer is no. So for example, people will say, my grandfather had liver cancer. Well, grandfather may have had colon cancer that went to the liver, but it's not liver cancer per se, right? So when a tumor goes from where it arose to some other place, that's what we term metastasis or advanced or metastatic disease. So yes, you can have a tumor and it can show up in your lung. It doesn't mean that you have lung cancer. It may be breast cancer. It may be kidney cancer. It may be something else. Surgery. We used to say categorically for metastatic disease, no. However, we've been starting to rethink that a little bit, particularly for things such as liver, isolated lung, isolated brain. So it's not categorically no anymore, but we have to be very stringent about who we employ that on, because there's a very narrow sort of, if you will, window for that being effective. Way back in the back.
Dr. Nelson, I can't tell if you're mildly confident, and I can't quite understand what the bigger problem is.
Are you an engineer?
I'm a psychologist.
So the answer is both. I'm both excited, enthusiastic, and yet realistic at the situation that we're confronted with. Cancer is amazingly complex, and we don't have all the tools that we need. But by the same token, if you look just at the last 8 years, right, and at the things which have changed over the last decade to 15 years in terms of treatment. So for example, right, just about 15 years ago, the Human Genome Project was launched, right? It was, in short, about $1 billion to sequence the first human genome. I just saw that there's a company in California that will sequence your genome for $3.99, right? So in 15 years, we've gone from an astronomical cost, right, down to something less than $500. So I think that the pace of change, both in the basic sciences and in the, if you will, the sort of pipeline, suggests that in the next decade or so, we're going to be doing pretty well. Right? We'll be making a fair amount of progress. By then, I get to retire. Right? What I worry about is what happens the next 15 after that, because we haven't done enough investing, right, for that future. Yes, ma'am, in the green. That's a loaded question, you realize. So the question is, has there been a reduction in carcinoma of unknown primary? And does it really matter anymore? So there is a move within our field to not have cancers be characterized as lung cancer or breast cancer or colon cancer, but have them be characterized as cancers with ALK, cancers with RET, cancers with, take your pick, right? I think that in the foreseeable future, 5 years or so, that will be a trend, but it won't displace the anatomic variation and categorization of tumors. So maybe about the time I retire, it'll be that way, but not right away, I don't think. But yes, our molecular profiling has allowed us to be able to isolate and figure out where tumors come from at to a much greater extent. In the brown, sir. Oh, it can. Why can't it be both was the question. It can. Oh my goodness. Yes, sir.
Yeah. In addition to the pills that you discussed, is laser therapy targeting molecular activity in the tumors, is that advancing, and how is that working out?
Yeah, so the question was, can lasers be used to molecularly target within a cell? We've not been quite so good at that. What we have tried to do is to utilize probes, much like the Nano String type probe, right? Where you send something in and have it attached to some portion of the cell, and then you use either laser or radio frequency or something else to then energize that or to convert it into a toxin or something on that order. That's met with mixed success. And in large part because it's not so easy to get stuff inside of a cell. Right? That's a little bit tough to do and have it go to the right place. Right? Cells are pretty good about keeping things that they don't want or shouldn't have in them out, right? And only taking up things that they need to grow. So a little bit hard. Yes, ma'am. I'll come back to you. So the question is there any work on just keeping the chemotherapy in the tumor and not having it go everywhere? There's actually a long history of that, particularly with sarcomas, where they would isolate the limb that had the sarcoma and pump the chemotherapy through. Our gynecologic colleagues, so Dr. Bristow, Dr. Tawari, Dr. Randall, are doing what is called HIPEC, which is hyperthermic intraperitoneal chemotherapy for ovarian cancer. And that is also just restricted to where the cancer is. Yeah, it's not so easy to just get it to the tumor. Even if you inject directly into the tumor, it still leaks out. The blood vessels are really leaky in and around a tumor. They're not normal blood vessels. So the short answer to your question is no, UCI is not doing anything in that arena. A lot of people have tried, but we don't have anybody doing that. All right, I said I'd come back to you, I'm sorry. So the question was, what is UCI doing for multiple myeloma? Who's our lead, and do we have any clinical trials? So, yes, we do things in multiple myeloma. The lead is Dr. Kanwar Kahlon, Kahlon. And what was the next one? Clinical trials. Yeah, so just in the last year, there's been really exciting data on a couple antibodies towards molecules that are on the outside of myeloma cells. And one of them is on that list of 2016 recently approved drugs, one of those 5 that was approved this year. So yes, there is a lot that's coming out for the multiple myeloma, both sort of classic approaches, but some of the newer sort of chemoimmunotherapeutics are also looking pretty good. All right, I'm told not too many more. Yes, ma'am. So the question is, does UCI get any funding for cancer prevention or non-chemotherapeutic sort of clinical trials? Is that right? Did I get it right? So, yes. So, our former Cancer Center director, Dr. Frank Maskins, was the lead investigator on, to date, the only positive clinical trial for chemoprevention of colon cancer, well, of any cancer. Right? Another one of our faculty members, a junior faculty member, you would have seen his name up there, Dr. Jason Zell, does chemoprevention work. That's what he does. He works primarily through the Southwest Oncology group, doing very large, because you have to do a lot of patients to be able to show that you actually can prevent something. We participated in the chemoprevention trials for breast cancer. So those were the STAR trials for breast cancer. There's less work in our group for the alternative approaches to treatment of cancer. However, some of my colleagues would argue that the mind-body connection stuff that we were talking about sort of crosses into that realm. We do have the Samueli Center for Integrative Medicine, and we have a very good working relationship with them. Actually, one of our pharmacologists has been working with the herbalome, so looking at plants, and has an Eastern plant extract that looks to have some really interesting properties for controlling pain, nerve pain, and we're setting up to try that in some of the chemotherapy drugs and regimens that leave people with nerve pain. So there's some, but it's not as robust as, say, the folks that are doing the molecularly targeted therapies. Yeah, where does nutrition enter into this? So the question is whether there's a place for and a connection with diet and either successive treatment or development of cancer, or the lack of white cells. Sorry. In my brain, right? There's got to be a connection, right? The damage or the insults to our bodies, to the cells that we get, right, happens all the time. It happens from being out in the sun. It happens from taking an airplane trip. It happens from going caving, right? It happens all the time. And diet is part of our environment. And so again, in my mind, I'm I believe that there's a connection. However, it's really hard to make those connections. So, let me ask you, what did you have for breakfast 3 days ago? And you could tell me. Yeah.
And as I say, tomorrow is the best doctor in City of Hope is seeing me at noon.
So I think my point in asking you the question is that it's really hard to get a firm measure of what people eat, right? And so it's really hard if you can't measure it to be able to figure out if there's an impact on biology in some way, shape, or form. And so we just don't have the tools yet to be able to dissect that out. All right, I was told we had to be out by 9, so, all right. Thank you all.